Welcome to Cardiology section number 3. Follow with us as we review congenital heart disorders.
So we'll go ahead and define the heart sounds. So the S1 heart sound is when the mitral and the tricuspid valves close together. So since it's the first heart sound, we just call mitral M1 and tricuspid T1. S2 heart sound is when the aortic and the pulmonic valves close together. So that's why they got the nomenclature of A2 and P2, because they're just the aortic valve and it's part of the second heart sound. The S3 heart sound, it happens when you get a rapid return of blood splashing into generally a dilated ventricle. When you see the word S3, a test question, you should be thinking systolic heart failure right away. When you see an S4, it means a stiff ventricle. It means it's hypertrophic, it's very stiff, it's enlarged. So if somebody has LVH, they can have an S4. Somebody has hypertrophic cardiomyopathy, they can have an S4. If somebody has amyloid deposits inside the heart to making it really stiff, then that also would lead to an S4 heart sound. And then rubs, we think of pericarditis. Gallops, so gallop is just that they have the S3 or the S4 along with a normal heart sound. So S1 and S2 are normal. And then we get the S3 or an S4 heart sound associated with it. So an S1, S2, and an S3, we're thinking systolic heart failure. Add in an S4, then we've got diastolic heart failure, or we can be talking about ischemia. Inspiration makes pulmonic and tricuspid murmurs get louder. You're breathing in air, so it also means you're breathing, or you're pulling back in more venous blood, so it delays the closure of these valves, pushes more blood through them, and so it makes the murmurs louder. So the ASD is a very common heart murmur. This particular one here, they like to ask questions because it has some specific traits. It has a classic sign of a left parasternal lift, but it also has a pulmonic area ejection murmur and a fixed splitting of S2. What they mean by the fixed splitting of S2 is if this guy's head was the left atrium and this was the right atrium, there's a hole here, so blood goes from the left atrium because it's the stronger of the two and pushes it over to the right side. Since the right atrium now has more blood than it normally did, it'll push more blood to the ventricle and then more blood into the lungs. Since there's more blood here, it'll delay the pulmonic valve from closing. So you'll hear the aortic valve close first and then the pulmonic valve, and that's why they say they got fixed splitting, because there's always the blood shunting and then there's always going to be that delay. So fixed splitting is pathognomonic with ASD, something that you should remember. Because there's more blood shunting from the left to the right side, you get dilated pulmonary arteries and an increased pulmonary vascularity. And the interesting thing about an ASD is there is no murmur to hear. Instead, you're hearing the pulmonic area ejection murmur because of all the extra blood shunting over. The EKG may or may not have a right bundle branch block, and if you leave an ASD alone, it's possible it can lead to pulmonary hypertension if it's not repaired. And to repair it, we use a closure device. So remember the fixed splitting of S2, it's really important, and this dilated pulmonary arteries. Coarctation of the aorta. This is claudication in young kids. When we have claudication in an adult, we think peripheral artery disease, but in a child, you should be thinking coarctation of the aorta. They have this narrowing of the aorta, and so it's just after the left subclavian. So the blood pressure in the arms will be equal. It'll be high, but it'll be really low in the legs. So you get this radial femoral pulse lag. So if you were to check a pulse at the radial and at the femoral artery at the same time, you would feel the radial pulse before you felt the femoral pulse, and so that's called the radial femoral pulse lag. So they get claudication with activity. When they run, they'll get these cramps in their calves. They have to rest for it to go away. They also have a rib notching. They'll have this 3 sign that you'll see on the x-ray where the coarctation is. 60% of these kids who have coarctation have an associated bicuspid aortic valve. 10% of the coarctation patients who have this bicuspid aortic valve also will have a risk of getting cerebral aneurysms. Cerebral aneurysm, what it means to you is that it is a risk of a subarachnoid hemorrhage, or the worst headache ever. Question could be, patient comes in with coarctation of the aorta, has a bicuspid aortic valve, undergoes surgery. Surgery goes well. 3 days later, the patient complains of the worst headache of his life and now is comatose. What do you suspect happened? I suspect he had a cerebral aneurysm, it ruptured, he had a subarachnoid hemorrhage. Coarctation is 2 times more likely to happen in men than it is in women, but there are ladies who have Turner syndrome. Coarctation is actually very common. Just Turner syndrome is not very common. So overall, men twice as much as females, but in females who have Turner syndrome, coarctation is very common. A PDA, this is a continuous machinery murmur. It happens throughout the cardiac cycle. It's both diastolic and systolic. You always hear it. It's not just in diastole or in systole. It's constantly happening. This is typically seen in a baby. It can go on if it doesn't close to an adult and be undetected. So the baby have presentation like failure to thrive, and it's common with congenital rubella. So the treatment is, when they're a baby and we hear it, we can give an indomethacin. This inhibits the prostaglandins, allows the PDA to close naturally on its own. If it doesn't, then we can go in there and do surgery. If you make it to adulthood and it's asymptomatic, then mostly it's just left alone. But remember, it's a continuous machinery murmur. You hear it throughout the entire cardiac cycle. The VSD, it is the most common of all the defects, very common in Down syndrome. You get this pansystolic or what's called holosystolic murmur that radiates to the midsternal border. It starts with initially from the left ventricle pushing over to the right ventricle. But over time, as the pressures, you're pushing more blood into the right side, the right ventricle has to get stronger, causes the pulmonary arteries to get pulmonary hypertension. Eventually, the pressure will get so high in the lungs, the right ventricle will get so strong from the shunting that the blood will actually shunt then from the right to the left side. And that's called Eisenmenger's, when you have the shunting due to pulmonary hypertension going from right to left. So left to right is normal, but once it shunts from right to left, it's called Eisenmenger syndrome. And this is a condition that's irreversible. Once it shunts left to right, we can do surgery and fix it. But once it's going from right to left, you can no longer do surgery to repair the problem. If you do the surgery and close it, the left ventricle won't be able to push and the right ventricle won't be able to push blood into the lungs. So they end up not making it. Tetralogy of flow, you're going to have to know the components. Invariably on the pants, they love to ask you which one of the following components is missing, or they'll give you 3 of them and ask you to identify the 4th one, and they'll have 5 answers for you. So you have to know it's pulmonary valve stenosis, a VSD, overriding aorta, and right ventricular hypertrophy. You have to memorize these. It's a boot-shaped heart. It's associated commonly with Down syndrome, DeGeorge syndrome, and babies who their mother gets congenital rubella. There's surgical correction for the tetralogy of flow. Often they don't get surgery, and what happens is, because this is a central cyanotic condition, your red blood cell count will go up to carry more oxygen. In other words, they're shunting blood already from right to left when they're born, so they have low oxygen state. The body wants to respond by creating more red blood cells so it can carry more oxygen around. So because of this, their red blood cell counts can get really, really high. The blood can get very, very thick, and this leads to clotting and strokes. So we can make things worse. So we can do phlebotomy to draw the blood levels down so that it's not too thick and allow them to function. So remember the 4 components. There's this thing called a TET spell. It's when these kids get dizzy when they're active and running around. So what these patients will do is they'll squat down like a catcher in baseball. And when they squat down, it actually increases the peripheral vascular resistance, and it causes the blood to shunt the opposite direction. So it's right to left, which is deoxygenated blood going to the oxygenated side. When they squat, increased peripheral vascular resistance actually temporarily shunts left to right, pushing oxygenated blood out where it normally should. And so these kids will pink up and feel better after they squat, which is why they end up doing it after they get dizzy. And so this is called a TET spell. So note that the shunt is normally right to left with this tetralogy of flow, and the squatting will actually shunt it to normal, the way it should be, and they oxygenate better. Transposition of the great vessels. It's not actually a blueprint topic, but it's part of the cardiology section. It's common in children that are born to diabetic mothers. And what happens is the aorta and the pulmonary artery are switched. So the left ventricle just pumps to the lungs and the right ventricle pumps to the body. They're not connected at all. This is not compatible with life. So the children that do get born, they have a PDA, an ASD, or a VSD that allows the blood to shunt over if they're going to survive this defect here. So these children will be born, it's a transposition, it'll just be left to the lungs and right to the body with a PDA or an ASD or a VSD. So they won't correct this problem until they fix the shunting here, and so they just do surgery. They know that it's happening when the baby's born. They'll be able to see it on the ultrasound, and then they'll prepare the parents and the baby for it after he's born. So Eisenmenger syndrome, talked a little bit about it when I was talking about the VSD. It's right heart failure caused by pulmonary hypertension. So the pressure in the lungs gets so high, it causes the right ventricle to actually start shunting blood from the right ventricle over to the left. Normally, blood will shunt from left to right because the left ventricle is stronger. But eventually, the right ventricle, because of all the extra blood it's getting shunted over to, and because the pressure in the lungs will get higher and higher, will get actually stronger than the left ventricle. And when this occurs, the right ventricle will start pushing blood across to the left ventricle, pushing deoxygenated blood over, and we call this Eisenmenger syndrome.